This is an honor. It's been a long time since John and I have done No Suits, No Slides. I'm Dave Gilbertson with UKG.
And I'm John Frehse with Ankara.
And we are going to talk to you today a little bit about the labor market. We do this video series. We've been doing it for about a year now. And every time we kind of talk about important topics in the labor market. What's going on with the labor shortage? Is there any relief in sight? And today we're going to talk about the healthcare market.
Maybe it's 2 years, by the way. We've been doing this.
It is a long time. It is actually.
We learned that we have to do a high top so no one can see my socks. It's part of, part of the problem.
John is known for his crazy socks.
And only for my socks.
So now we'll just get the reflection off your head.
Yes, I'm excited about it. Thank you. Thank you.
Exactly, anytime. So in the healthcare labor market today, we've been tracking the labor shortage in the labor market. You and I have talked to a number of healthcare companies, a number of healthcare conferences. My personal sense is that in looking at all the data behind the workforce activity in that market, where people are working, where they're not working, how that compares to pre-pandemic, my pretty strong sense is that the labor shortage has hit the healthcare market harder than any other sector. Workforce activity is at about 90% of where it was pre-pandemic in healthcare. Every other sector has gotten back above where they were pre-pandemic. If you look at the different segments within healthcare, skilled nursing facilities are having an impossible time hiring people, right? You've got relatively low wage jobs and roles where folks that might have taken that job pre-pandemic, now they're looking at it and saying, do I really want to work that closely with people in the midst of a pandemic? And by the way, there's a bunch of work from home jobs that are available at a slightly higher pay.
These are by the way, not beautiful jobs always. I mean, this is tough work at
Very
$15,
tough.
$16, $17 an hour, and there's so many other options. And I think what we're going to get into at the healthcare piece is it's not one thing. There's a stack of things working against this industry, and SNF, skilled nursing facilities, that's one situation. Mm-hmm. Hospitals and health systems is another.
That's right.
Acute, subacute, they're all in trouble, but it's for all different reasons.
That's true. I wish there was some shining lights out there that we could point to, and I agree. I don't think there are. Within hospitals, one thing that we've seen very consistently are as nurses that have been in this business for a long time, really heroes through the pandemic and what they've worked through and dealt with personally with their family and then certainly at work. A lot of them have decided to retire, and a lot of kind of pre-pandemic, we saw older folks that were waiting longer to retire, so they were working deeper into their life. And now all of a sudden, a lot of those nurses are saying, you know what? I'm in my late 50s, early 60s, mid 60s. I've kind of had enough. I've done my duty, and I'm ready to take a step back. The younger nurses are coming up, and there actually are enough younger nurses out there to replace the ones that are retiring. So that's great news. However, they're looking at it and saying, I could be a travel nurse, and if I'm 22, 23, 24, I've got not a lot of connection to my community. I don't mind traveling for a while, going, one place for 6 months and 6 months and 6 months. And by the way, I can make $150 an hour, $100 an hour instead of what I'm making in a permanent role.
When you take out all those agency fees, we're still looking at a 23-year-old making $200,000 a year.
That's right. Yeah. And that is really hard to resist. If you're the hospital, boy, does that put you in a tough spot.
Very difficult. Yeah, and I think that, going to the stack of challenges, one is if you look at health systems in the U.S., 53% of them don't make money right now. They're not profitable. They're losing. And the model is wrong on so many levels. There's certain things we can control, certain things we can't. The revenue stream and the shape of the revenue, is it behavioral health? Is it acute? Is it, ortho surgeries, which are highly profitable, which went away during the pandemic.
Right.
What is the mix of care that you're providing is one story. Are you dealing with Medicaid patients? Are you looking at private pay, or what's the situation? Sure. But revenue is one side, cost is the other, and we go back to labor, which is where you and I spend all of our time. Yep. The labor story is terrifying, and the travelers is one piece, but it's the agency work in general. If I'm working in a hospital, I've got a friend who works in northeastern Pennsylvania in a hospital, and he realized as a respiratory therapist, making about $110,000 a year. Mm-hmm. Other people were going to be travelers and coming back and making $200,000 a year.
Right. Sure.
in the same jobs
Right.
at the same hospital.
Right.
And so he did the same thing and he almost doubled his income and he's doing the
Wow.
same job and nothing
Wow.
changed.
Right.
So this is how we are bankrupting the healthcare system in the United States. That's one of many things that are wrong. The question is, what are we going to do about it? But before we get there, this is something that
We are promising to get there at some point, though.
we will. Stay tuned.
Right.
But it's something that administrations did to themselves. They said, yes, we've got a short-term challenge. Let's bring in travelers.
Yeah.
And that's a self-perpetuating problem. And in California, the law now states, I'm not going to get it exactly right, but you have to be, I think, at least 40 miles away from the place where you're traveling to.
Yep.
So that you can't do what's happening in Pennsylvania and every other state.
Right.
But there was a lot of price gouging during the pandemic about this, and it was very concerning. So as we look at this and the job hopping and the ability to do these things, it's leadership teams in hospitals and health systems that are part of that problem.
Yeah.
By looking at short-term solutions that are long-term destruction.
You can't pay your way out of this.
No.
Right? I mean, for hospital systems, they're not going to be able to buy their way out of this.
And this is a great example of trying to buy your way out of this and going bankrupt.
Right.
And the bankruptcies that Ankara works on right now are, I would argue, 50% related to travelers. And it's a little bit more, a little bit less wherever we go. And again, can you fault them for this?
Right. Oh, absolutely. If you're in the shoes of a 23, 24-year-old, I think most of us would make the same choice if we had that flexibility.
Now, the skilled nursing facilities are different. And
yes, that's a totally different problem to solve. Yeah. Home health and hospice as well.
Yeah.
Right? It's a very different problem to solve.
We've got clients in both of those spaces. I think hospice workers in general are a different breed. Like the ability to do that kind of work. I know it's something that I could never do, and there's burnout there, and it's difficult.
Yep.
But on the SNF side, I think it's fascinating that we're in a situation where somehow as a society, we believed that the warehousing of the elderly and then supervised by $15 an hour low skill employees. Yeah. And by the way, they're supervised by one or two skilled nurses.
Sure.
Was somehow okay.
Yeah.
And this was going to work.
Right.
And so if you look at senior living in general, right, as a sort of step down, it's a disaster.
Yeah. Yeah.
What?
It's no wonder that they want to age in place, right? That they want to stay home as long as they can, because going into one of these facilities, it's just not something that you'd look forward to in your life.
Yeah, so the age in place brings up another topic, and I know we're covering a lot of topics in a short period of time, which is value-based care. And value-based care is really the idea that we're going to care for you less. We're just going to do it so well the first time that you don't come back. If you have this problem, I'm going to give the health system $2,000 to solve your problem.
Yep.
You don't get $5,000 if they come back 3 times.
Right.
You got to get it right that first time. And so that the value-based care story is a model that's happening around the country. And I think health systems should be terrified by this because they don't have their act together.
Yeah.
So
it'll be interesting. Last point before we get on to solutions, it'll be interesting to see the effect that regulations will have. I've seen a lot more states coming out with regulations saying regulating the number of nurses you have to have per bed capacity.
Yes.
Right? So that means you got to be really good at forecasting your bed capacity. And then you have to commit to a certain level of staffing. Feels like that's just going to drive up the cost of healthcare.
It's what they do in California, which is where there's a lot of bankruptcies right now. We've done multiple bankruptcies in California, multiple health systems. And, a lot of the CNOs, the chief nursing officers, they talk about revenue in terms of, they call it heads and beds. How many heads and beds do we have? Or a census. And they are looking at those, the nursing ratios, and it is causing a lot of problems. Now, there's exceptions to the rule where there's surges and things that happen you can't control. But it's a problem.
Yeah. So, all right. So we've talked about nurses retiring, younger nurses getting paid exorbitant fees to travel around the country.
And exorbitant is subjective.
Exorbitant is very subjective.
They would not say exorbitant. They would say finally. I mean,
so they're getting paid much higher than they would have otherwise. You've also got in other parts of the healthcare sector, folks that are actively wanting to work different types of jobs at higher pay. And you've got a lot of these variables that are out of the control of health systems.
And value-based care coming around the corner.
So I'm not seeing solutions there. Get us out of this, John.
All right, so
how do we do it?
There's two pieces to this. One is operationally, and I shouldn't quote Michelle Mader, who is one of my peers at Ankara, but I will anyway, without her permission. When we look at the ED, so emergency, right, that is really the revenue engine for the hospital.
Sure.
So it's the same for other facilities. There's an entry point, okay? And if we don't have the right capacity at that part of the operation, it's almost like human supply chain. How do I get people from here to here to here?
Yeah.
Well, if I have a choke point in the beginning, we have diversions.
Right.
And so whether the ER is not, or ED, emergency department, is not big enough, doesn't have the right bandwidth to handle patient load, we have diversions. They go to other health systems in the area, and we lose that revenue and the ability to put them in, or they give up, right? And so that's one story. But if we don't have the right staffing, just to put the final cannonball on top of everything we're talking about, if they don't have the right staffing there, even if they've got the capacity, the physical capacity, the beds, the infrastructure, they have to go on diversion, right? The ambulances go somewhere else. And by the way, in some of these communities, they want the ambulances to go somewhere else because they've got money-losing patients coming in the door, but not always.
But not always.
So it's tricky. And by the way, sometimes all the hospitals will go on diversion because if they're all on diversion, nobody's on diversion.
Right.
Then they all. It doesn't matter if you're on diversion. We're still coming.
Right.
So structurally, we have an issue. Labor to serve those folks, the intake of revenue into your health system. Skilled nursing facilities, same thing. We run out of beds, but we've got all Medicaid beds. Well, Medicaid beds may be $1,500 a month,
right?
Versus something else. So those are all concerns. So now we talk about solutions. Some of it's technology, and some of it's ripping the Band-Aid off, which is sort of like an awful healthcare metaphor. Yeah. When we think about technology, I think about two things. One is efficiencies in the marketplace, and the other is how do we engage the workforce in a real and meaningful way. And give them the flexibility. You talked about the 65-year-old woman who says, I've had it. It's enough. She may have had it with 60 hours a week and forced overtime as a full-time employee, mandatory overtime. But she still may love being a nurse.
That's true.
So question one is, do we have the technologies and infrastructure to have people work 1 to 2, maybe even 3 shifts a week on occasion, and not mandate them to do this work? So I'm going to kick it over to you.
Make those float pools available across facilities within a community. Big impact. It's going to take coordination. One other element of technology that I would throw in there is workflow, right? If you can automate as many of the workflows as possible behind the scenes, then it alleviates some of the cost challenges on the kind of non-clinical care part of the hospital. And it allows you to kind of focus all of your efforts on making that clinical care as great as possible.
And what we're finding is, and again, Michelle Mader she's on the floor doing this stuff, is, wow, we're wasting a ton of money over here and we're short over here. And so in a world where there's an acute talent shortage, at least it appears to be a talent shortage based on what's going on, we need to make sure we're leveraging these people effectively. So one is, let's get them into the right place. The other one, though, and this was very interesting during the pandemic, there's a lot of technology launched around talent pools in communities. There's some that are good and there's some that are bad. One that I think is bad, and I won't go into names, is you basically have people signing up on an app that are skilled nurses or whatever, ICU nurses, whatever. And what they allow the health systems to do is bid on those people. Hey, if you come in on this day, I'll pay you $110 an hour. And then it's an auction. Somebody else can bid. And what they found is hospitals in the same health system were bidding against each other. And driving 140, 150, and it was they were killing themselves. Now on the opposite side of that, there's a company which I will mention the name of.
Great for the nurses, though.
Yeah, it's great for the nurses. There's two things. One is, if you have, and we'll do a little UKG plug, if you have a robust platform to do workforce management, you can actually do that float pool inside of the technology. And you don't need to
even if they're contractors, you can do per diems, you can do
So you have the ability to get efficiencies in the marketplace through UKG. Great. If you need to go outside of that, there's a company called ShiftMed, which I've become a little obsessed with.
I've seen them,
And they, instead of this whole bidding and everything else, they say, and by the way, it's the #1 downloaded app in the App Store for healthcare. And they have over 100,000 W-2s on their own payroll.
Really? Oh, interesting.
And they encourage clients to steal their employees. So first of all, you come in, it's going to be $25 to $30 cheaper an hour compared to the agency.
Yep.
But what you do is you get those people in the door. This is part of the solution. You get them in the door for a shift.
Yep.
And your CNO has an opportunity to audition for them.
Yep.
Hey, this is what our hospital looks like. This is our culture. We'd love it if you'd
Yeah.
work as many shifts as you want.
Yeah.
And maybe come full time.
Yep.
And that's a way to steal talent.
Right.
In a way that this
Absolutely.
technology platform is set up. It's actually
Yeah.
set up to bankrupt all the travelers.
Yeah.
Which is great.
But it's also kind of a subtle recognition that that the employees are in more control now than they were before.
That's a great point.
Right.
That's a great point.
Yeah.
Yeah, and so I think that is a really big story, is creating a free market that is not a race to the bottom in bankruptcy.
Yep.
But if you have an efficient technology, and yes, UKG internally, let's get the right people in the right place at the right time. Let's give
Yep.
them flexibility. Let's empower them to do the shift swaps, sign up for overtime and time off, all that stuff. And let's look at broader market technologies that say, because we're so efficient, we don't need to charge $50 an hour for our services,
Yep.
and then we give $100 to the nurse.
Right.
We'll
right.
charge $20,
Yep.
and we'll give the 30
Sure.
back to the
Sure.
health system so that they don't go bankrupt.
Mm-hmm.
But it's about engagement. It's about a range of issues. Do you want to take us home with a little bit of the summary?
Sure. Yeah. So what I would wrap up is, I think what you're proposing is the healthcare system is going to become the voice very quickly. Right?
Very quickly.
The singers or employees are trying out for the judges, and then all of a sudden, when that chair turns, the judges are trying out for them.
Yeah.
Right?
No, absolutely.
It is
I
a
think you're right.
competition for which of these 4 hospitals are you going to be working with, and they're all vying for your attention. It's going to be really interesting because there is all of a sudden a lot more parity in who's got control now, more than we've ever seen before.
Yep.
So just to wrap it up, I think we talked from a solution standpoint. We talked a lot about technology and the way that technology can really automate the workflows. It can be used in a much more innovative way than we've seen in the past to kind of aggregate float pools around one community. And then we're also talking about kind of the infrastructure and what you're doing to invest in the infrastructure to try to get as much through the system.
What's that revenue engine, right? Where is it going to go?
That's right.
And I think that's the
right.
story.
Yeah. John, pleasure as always.
Thank you so
Almost
much.
always.
Well,
I don't know if it's always a pleasure, but it's almost always a pleasure.
He just couldn't let it go.
I couldn't
do
resist.
it.
Sorry.
He couldn't do it. Another episode of No Suits, No Slides in the books.
Until next time.